Hello everyone, welcome back to part 3 of the dementia series. Again, my name is Shalon Sullivan. I am the speech language pathologist at Martin County Hospital, and I am going to talk to you about what the treatment options are for dementia processes. So we're going to start with medication treatment options. So each of these are individualized. None of these are specific to a type of dementia. They are used, some of them are used just one of them or in combination. And all of that depends on your doctor, your provider, where you are in the dementia process, and just what your treatment plan is. So these are just some of the options that are available. This list is not exhaustive, so again, just talk with your provider, have him or her explain to you why certain things aren't an option, or why, one medicine or treatment approach over another. I feel like it's very important to have those conversations so that you can be an active part of your treatment plan. So let's get started. So there are a couple of different classes of medications. So there are a few that are anti-amyloid drugs, and these are going to be the drugs that actually rid the body of the beta amyloid protein. Now, by doing this, obviously it is intended to stop the protein pathology that causes the appearance of protein plaques in the brain, which in turn should stop the progression of the disease or greatly slow it down, because of course, like we talked about before, once you are experiencing symptoms and seeking treatment and getting your diagnosis and everything like that, there's a certain amount of damage that's already done, a certain amount of process that's already in place. So I just want to reiterate that this is not a cure, this is just a treatment. So the first one of these anti-amyloid drugs is Aduhelm, I believe, Aduhelm. It is no longer available. It was kind of fast-tracked through the clinical trial program, and but it was discontinued in 2024. However, there were two other identical drugs that received traditional FDA approval, Kisunla and Leqembi. So those are two drug options. They're a 2-time-a-week IV infusion therapy. The greatest risk factors associated with these types of treatment is brain bleeding and brain swelling. So obviously your provider is going to do some testing. There are genetic tests that can be done to tell you if you are at a very increased risk for these side effects, and then also just your history, certain imaging, so that you and your doctor can decide whether or not the risk outweigh the benefits or vice versa. So those are those drugs. And then we have a different class of medicines that that manage the symptoms and kind of make what is left work best, if that makes sense. So we have the cholinesterase inhibitors, which they prevent the breakdown of acetylcholine. So when you have increased levels of acetylcholine in your brain, then you have better communication within your brain and better communication between your brain and your body. So that's a good thing. So that's what these drugs like Aricept, the Exelon patch, Razidine, those medicines increase neural communication or neural transmission. And then we have glutamate regulators, which, like we talked about, a lot of the process stems from hypometabolism of glucose or glutamate in the brain. And so these medicines like Namenda are going to regulate the glutamate in the brain to help with that metabolism issue as well. Then you have this drug, Namzaric, which does both of those things. The way that they may choose is they may consider which option is best based on what stage of the disease you're in. At some point it may be a moot point to attempt one or a few of these options. So like I said, none of these drugs is for everyone. Some may use one, some may use a combination. It's really up to your neurologist what will be recommended for you. Also, then there's the behavior and psychiatric management. Most individuals with dementia are going to be on some kind of sleep aid for insomnia, and probably a mood stabilizer of some sort to help with the agitation and paranoia that come along with. So those are some of the medicines you may ask your doctor about or expect to see. And I encourage you to have a conversation with your doctor about what your goals are with these medicines as well. Next is cognitive therapy. So most people who have dementia will be prescribed or referred for cognitive therapy, and that's where I come in. As a speech-language pathologist, cognitive evaluation and treatment is within my scope of practice and is my area. So we start off by doing cognitive testing. As I mentioned in earlier parts, many times this begins during your diagnostic process with your PCP or your neurologist. And then after we do the initial testing, we discuss, I do a lot of education. We talk about compensatory strategies. We talk about establishing routines. We talk about cognitive exercises and engagement to stimulate cognitive function in a functional activities of daily living, really living life to stimulate the brain in a meaningful way. And then, like I said, I do lots of patient education and monitoring throughout the disease process. So once you feel like what we are doing isn't working anymore, then you come back, we retest, we see where we're at, and then we establish a new plan with new strategies. And that goes on throughout the disease process. Another part is establishing resources and supports, establishing a plan throughout the process, because each families and each person with dementia has a different plan that works for them. Some have a facility in mind from the beginning. They know that once they get to a certain stage of dependence on others, they want to be in a facility. Others want to have caregivers come to the home. Others want to stay with a child, and others want to be cared for by their spouse until they have to rely on outside caregivers. So everybody's plan is different. None is better or worse than the other, but we want to establish a plan as early on as possible so that we can be prepared, and you don't have to make hard decisions when it's a more stressful time. And that way you can involve the person with dementia in their own care and get their own, make sure that their wishes are being upheld. So I'm sure that you've noticed that a lot of what I've told you about mentions the stage of dementia. Whenever you're being diagnosed, we're trying to establish what stage of dementia you're in using objective testing and functional rating scales, and along with imaging and all of the things, as well as treatment options. Your treatment options also depend on what stage of dementia you are in. So I want to go over what the stages of dementia look like in a very general way. There is a lot of detail to the stages of dementia, but these are some general ideas of what early, middle, and late stage dementia look like. So starting off at early stage dementia, so we use the global deterioration scale, and the rating scales 1 through 3 are considered, 1 is normal, and 2 and 3 are very mild and mild cognitive impairment. So this isn't even formal dementia if you're a 1, 2, or 3. So once we get to a score of 4, then you are considered early stage dementia. At this point, The person is still living at home, still independent and self-care, but they are noticing a difference in their cognitive abilities. At this point, they're probably no longer able to work, have the organization to hold down a job, even if it's one that they've had for many, many years. At this point, they can make plans before actions. They can still be novel, creative, and spontaneous. So while it's a very big change for the person experiencing the dementia, a lot of times many of their loved ones may not notice yet at this point, even in early stage dementia. At this point, you see the third bullet there says approximately a 1 month plasticity of routine, and what that means is you can have a functional and familiar routine as long as you haven't departed from it for longer than a month. So an example of this situation might be if you were to have a fall or an event happen where you had to have an extended illness where you had to be hospitalized and then maybe do a few weeks of rehab. If you are away from your routine for less than 1 month, then you can return back home to your familiar environment and your familiar routine with very minimal trouble getting back into routine. But if you're gone for about a month or longer, well, then the hospital has become your new routine. So when you go home, then you're going to have to reestablish a routine. So it's going to take longer to get back into the swing of things. And this is something that we try to take into consideration when we have patients who have a dementia diagnosis, is where they are in the dementia process, and about what stage they're at, so that we know how much importance we need to put on getting them back home to their familiar environment and to their established routine. Then we have middle stage dementia. This is a global deterioration scale level 5. There's always an age equivalent. Here it's the cognitive match of a teenager. I always want to stress the importance of when you're dealing with patients with dementia and they have an age equivalence, that is strictly for supervision purposes only. You do not treat the person with dementia as if they are younger than their age. You don't disrespect them or talk down to them. This is strictly how you gauge what level of supervision that they need. So at this stage, you would supervise them as you would a teenager. So for instance, if you have a teenager, maybe you leave the house to run to the grocery store, the post office, but you're not going to leave them for the weekend alone, unsupervised. So that's just how you kind of gauge how much supervision that you need. They can learn new tasks, simple tasks, with lots of repetition. Routine is a substitute for memory at this point, and you have approximately a 2-week plasticity of routine. So now you've only got about 2 weeks to get back to that familiar environment and established routine before you're having to start all over and create a new routine. They may need setup for tasks and distant supervision. So at this point, they can probably still feed themselves and groom themselves, but they may need you to set out the tools to do it. So maybe you fix their plate and give them their silverware, or you set out their toothbrush and their toothpaste, and then they can complete the task with that setup assistance. Change is most noticeable to family and very close friends at this point. Okay, next is late stage dementia. This is global deterioration scale level 6, cognitive match to ages 2 through 6 years old. So You would supervise these individuals as you would a child of 2 to 6 years old. So obviously you don't leave this person home alone while you leave, and really at this point you decide if you're able to leave this person in a room alone. This is usually the time where you decide if you need a 24-hour sitter, or if the person is more appropriate for a facility or a lockdown unit. So each person is different and each situation is different, but those are some considerations that need to be made. At late stage dementia, the person will need up to total assist in all care and dependent on others for survival. So that means assistance with eating, grooming, bathing, toileting, as well as introducing needed items. So they're not going to take their meds without being given their meds. They're not going to drink water without being given water. They're not going to get something to eat without being fed. And so that's what it means by completely dependent on others for survival. And then, of course, towards the end of this stage, then the patient becomes bedridden and no longer to eat or drink. They also become unable to communicate or mute, and that's what the end stage looks like. There is another stage, which is terminal stage dementia, and of course, past that point, they're of course not eating, not drinking, and then eventually do pass away. So that is just to kind of describe what the stages of dementia look like. Most treatment is recommended to begin in early stage dementia or during the mild cognitive impairment stages. So that's why it's also important to get your diagnosis early so that you have greater treatment options, because many of the treatment options, if started during mild cognitive impairment, have a greater success rate. But other medicines can be started during mild to moderate dementia, but no medicines start past mild to moderate dementia. Usually, my experience is most doctors are pretty hesitant to introduce medicines past early stage or mild stage dementia. So that's it for this week. That's part 3. Come back and see me next week, and we're going to talk all about Alzheimer's disease specifically. So thanks for coming.